In the 1970s, narrow diameter implants smaller than 2 mm diameter were very popular in Europe and South America. These pin implants were often used in 2 or 3 sets for each tooth. They did not maintain crystal bone, often would fail or fracture, and became unpopular after the 3.75 mm diameter root form implants were developed. More recently, these implants have re-emerged in the marketplace. Mini implants were used to immediately restore and support a transitional prosthesis. Indications of these mini implants: first, immediate stabilization of a fixed or removable prosthesis. Second, transitional stabilization of prosthesis during conventional implant no-load healing period. Third, immediate support for compromised natural teeth, especially in periodontal disease and endodontic problems teeth. 4. Interim abutment for failing fixed or removable prostheses. 5. Orthodontic anchorage applications. 6. Compatible with all existing implant systems. 7. Provisional repair of a broken prosthesis. The mini dental implant system component include different shape of these type, and they have a housing part that are fitted in the prosthesis. They may be a square shape head or a round shape. Mini dental implant features. Implants are surface etched, self-tapping thread design, high-strength titanium alloy material, and may integrated abutment. They have 1.8 to 2.2 millimeter in diameter, and they available in 10 to 18 millimeter lengths. Implant and abutment are a single unit. They may have oval and square head abutment design. We can see the difference in the size and diameter between the conventional implant and mini dental implant. And we can see here the unique self-tapping design of the mini implant does not require the same bone preparation that need in the conventional type. These are the different current design available nowadays. The materials of these mini dental implant may be titanium, commercial pure titanium, or titanium alloy, especially the titanium 6 aluminum for vanadium, because these titanium alloy have a higher tensile strength than the strongest commercial pure titanium. The advantages of mini implant: first, minimally invasive surgery. Second, cost effective. Immediate loading, suitable for resolved ridges, Minimal post-operative discomfort can be used on almost all ridges, can be performed by the patient general dentist. So we have the question that, is this mini dental implant the end of conventional implants? The answer, no. Mini dental implants are an alternative to dentures, bridges, and conventional implants in certain situations. They are often a third way in between dentures and more complex implant treatments. The patient will end up with a different product compared with a conventional implants, and the most important thing is the patient the choice. The patient groups that are more indicated to mini dental implant are the medical, like minimal surgery in nearly all groups, financial, that they have a low cost, and the anatomical, with the patient have atrophic ridges. This patient have a bruising with a flap surgery conventional implant placement, so they are not indicated for this surgery and may be indicated for mini dental implant to avoid the invasive surgery. Many patients who would not consider conventional implant treatment due to fear of complex surgery, time scale of treatment that may reach up to 2 years, and the cost of the conventional, the limited bone availability. These patients do not want grafting, may proceed with mini dental implant. So the patient selection criteria: who is a candidate for mini dental implant, difficulty wearing lower denture, cannot tolerate a palate on the upper denture, and anatomically compromised. Patient wants to feel more confident. Are mini dental implants good for everyone? We start with the medically compromised. A wider range of patients can be treated with mini dental implant because they not need incision in most cases, and low morbidity, low infection, and non-invasive surgery. The patient taking steroids are contraindicated for most implants, but that they can be treated with mini implants. And the patient taking blood thinners, less of a problem unless a flap is needed. Consult with patient's physician so that to decide for the indication of the treatment. Many patients do not have adequate bone support to accept the large size of conventional implant. The mini dental implant can be used in almost any ridge and on patients with severe alveolar ridge resorption. The treatment with mini dental implant need fewer visits to the dental surgery and can be performed by the general dentist. Their biggest application of mini dental implant is in the stabilization of complete lower denture. The contraindications of mini dental implant: first, the medical, like psychiatric disease, chronic facial pain syndrome, history of infected endocarditis, rheumatic fever, sometimes contraindicated. Second, the surgical, like severe jaw atrophy, so no space will be available for the implant to be inserted, greater density of the bone, heavy occlusion, gross dental sepsis, immediate tooth replacement. Mini dental implant diagnosis and treatment planning. The treatment plan must include occlusal dynamics, oral hygiene, general health and medical history, psychological social status, aesthetic like a smile line, and the anatomy. Panoramic radiograph must be taken for the diagnosis and the treatment. The anatomical considerations involve the position of the mandibular nerve, mental nerve and foramen, submental artery, maxillary sinus, nasal sinus, and other adjacent teeth or roots. Bone quality and quantity. The rate of density, as classified by Atwood classification into 1, 2, 3, and 4. The 1 is very dense bone, difficult surgically. 2, moderately dense bone, classical mandibular bone. 3, low density bone, maxillary bone or soft mandibular spongy bone, which can modify the protocol for treatment. And type 4, very low density bone, which is poor candidate for mini dental implant and other type of conventional implants. We can see here the type of bone in different density. To assess the bone, we must know the height, width, shape, angulation using ridge mapping radiographs, CT scan or CPCT, sectional radiograph, and extra. the radiographic planning. The panoramic X-ray assists in planning implant placement, and we can use a pencil radiograph in region of the canine and first premolar, anterior to mental nerve and canal, and by the pencil radiograph in the region of lateral incisor region. Then we can prepare the previously prepared denture to take the and here we can see the shape of the bone that can taken from the patient after applying of the aluminum foil around the denture and taking of the X. So according to the result of the X-ray, we can decide the length that can be used for each cases, like 10, 13, 15 or 18 millimeters. During the treatment planning, we must do a central marking and take the space from the central marking to the first implant about 5 millimeters. So between the two implants will be 10 millimeters. Each two implant there will be a 10 millimeters space, and from the central marking to the second implant there will be a 15 millimeters. So the area from the last two implants, when we used 4 implants to support a complete lower denture, there must be a 3 centimeter between them and a 1 centimeter away from the mental foramen. Implant placement procedure. We have a special kit and instrument that can used from each company that manufacture the mini dental implant. We start by construction of a complete lower denture, or we can use the previous patient dentures to complete the treatment. We mark the area that have to place the implants on the patient mouth and then applying the denture on it. So the marking that put in the patient mouth will be printed on the inner surface of the denture. So dry the patient's arch and place the denture in the mouth to mark the areas of mini dental implant. The second step is assess the vertical bone height. The mini dental implant are 10 to 18 millimeter length. Less than 10 millimeter will have poor candidate and use longest implant possible. And in the mandibular ridge, the mini dental implant must have 2/3 total height of the bone, and on the maxillary 90% of the Then we first palpate to assess the angulation of the ridge. After measuring depth by using the vernier to measure the length of the drill that must be inserted. Then we drill pilot hole with a tapping motion using saline irrigation and drill depth according to bone density evaluation. Then we start to insert of the implant without contaminate it from its insert implant into pilot opening through gingiva to bone. Take care not to trap tissue and rotate clockwise with down. Continue insertion of implant with finger driver until firm bony resistance is again met. Then follow with wink thumb. Range slowly again until firm bony resistance is met. So we insert the mini dental implant in the area until it will engage the surrounding bone. Sometimes we need to use a ratchet wrench. If bone is extremely dense, use of ratchet wrench is needed. Slow incremental turn will allow full insertion without snapping of the implant. The pressure should be applied downward on the head of the ratchet during insertion. If very heavy resistance is noticed, bag implant out and make pilot hole deeper. Do not force ratchet or implant that may snap at neck. So don't use a heavy force during torquing of the mini dental. After complete the insertion of the implant so that no thread are supragingival. Check primary fixation with the torque. Then take an X-ray, post-operative X-ray, to be sure of the accurate position of the implant in its place. Then the denture placement and the prosthetic technique. Positioning should be close to original plane. Make holes in denture with lab bare on a pre-marked location. So we must drill on the inner surface of the denture to make a space or enough space for the housing of the implant, so that no interference will be with the housing of the mini dental implant. And try to check the denture full seating using fit checker. Then we fill the holes in the inner surface of the denture with the implant housing attachment resin and protect exposed implant head to prevent engaging undercut. Place denture on O-ring housing and have patient bite gently using previous registration to seat denture and hold for setting of resin acrylic. After setting of the resin acrylic, remove the denture and assess security of housing in the denture. Then add flowable resin, light cured, cold cured acrylic or cyanoacrylate if loose. Trim the excess material and soft tissue surface of denture to avoid sore spot. Also shorten the borders of the denture. The post-operative instruction. The patient may need analgesic, ice applications, warm salt water as a mouthwash, and the patient instruct to wear denture for 24 hours, and we can see the patient in after 24 hours later. Adjust the denture. Most likely there will be adjustments and some will have denture source developing. Adjust the spot and check occlusion. Instruct the patient to wear denture as much as possible over next week and to call if there is any problem and then see the patient after 3 days and 1 week post-operatively.